Hi, everyone. Welcome to OsteoBites, and thanks so much for joining us today. My name is Christina Iptoma, and I am mom to Osteo Angel Dillon and Director of Scientific Programs at MIB Agents. And today on OsteoBites, we are joined by Dr. Matt Dietz from the University of Utah to discuss optimizing Ewing Sarcoma and Osteosarcoma Biopsy acquisition, the consensus recommendations from the Children's Oncology Group Bone Tumor Committee. Thank you so much, Dr. Dietz, for joining us on OsteoBites today. We are thrilled to have you. And thank you also to our panelist, Max, for joining us today. Please feel free to submit questions during the presentation through the Q&A in Zoom, and we will share those with Dr. Dietz after his presentation. And before we jump in, just a little bit about our guest. Dr. Matthew Dietz is an assistant professor of pediatrics in the Division of Pediatric Hematology and Oncology at the University of Utah. He received his degrees in medicine and medical education from the University of New England, and he completed his pediatric residency in hematology and oncology fellowship at Oregon Health and Science University, where he also served as chief resident. Clinically, Dr. Dietz focuses on the care of pediatric and young adult patients with bone and soft tissue sarcoma, as well as children with retinoblastoma. He's the Associate Medical Director of the Solid Tumor Program, and Dr. Dietz is committed to delivering a compassionate, cutting-edge clinical care, as well as providing patients with access to experimental therapeutics and discovery programs. Dr. Dietz's research efforts include team science approaches to better understand the biology driving cancer progression and treatment resistance, with a focus on translating this work into new therapeutic approaches. He's a member of the Huntsman Cancer Institute's Experimental Therapeutics Program and actively involved in the development of early phase clinical trials through multiple cooperative consortia, including the Children's Oncology Group, the Sunshine Project, the Pediatric Oncology Experimental Therapeutics Investigators Consortium, the Beat Childhood Cancer Consortium, and the Pediatric Early Phase Clinical Trial Network. Thanks so much for joining us today, Dr. Dietz. We're really looking forward to your talk today, and also congrats on the paper that was published on this topic this past December. I'll put a link in the chat to the paper, so if anyone wants to dig deeper, they have access to that. A few other announcements before we get started. Related to today's topic, the FDA has issued draft guidance on including tissue biopsies in clinical trials. The deadline for public comment was earlier this week on March 10th, but you can still read the draft guidance and see the comments that have been submitted online. So I'll put a link in the chat where you can find more info. And factor registration just opened last week. It is going to be June 26th, 28th in Salt Lake City, Dr. Dietz's hometown, which he can attest to how beautiful it is there. And thank you so much to the University of Utah, who is a factor sponsor this year. If you register before March 19th, you can take advantage of our early bird registration rate. So you have like another week to do that. Our scientific program will be announced shortly. It's going to be fantastic this year. I will put a reg link in the chat. We also have a conference room block at the fabulous Grand America Hotel, and you can take advantage of that discounted room rate by booking on our factor link. So I'll put that in the chat too. And lastly, travel award applications are open. We do have a limited number of travel awards for both scientists and osteo warriors. Scientists can apply on Proposal Central, and then osteo warriors have to be nominated by a healthcare provider. So if you know of an osteo warrior who would like to come to factor but just needs financial assistance, please consider nominating them. Travel award applications are due on March 28th for our scientific community, and then for our patient community, we can be more flexible with timing on that. The deadline on that is in June. So I'll put a link in the chat where you can find more info on eligibility and guidelines. And that's it for me. Max, could you please introduce yourself?
Hi, my name is Max. I was diagnosed with osteosarcoma in my right distal femur in 2015 when I was 10 years old. And since then, I've been more than 8 years NED, and I'm currently a student studying chemistry at Tufts. With MIB, I've been a member of the Junior Advisory Board for 4 years and an ambassador agent for 5. And now I'll hand it off to Dr. Dietz.
Thanks, Max.
Thanks, Christina and Max. And let me get my share going here. We'll do this. Share. And then I'll put it on to.
That looks great.
Does that look good?
Yep.
Great. Well then, thank you, Christina and MIB and Max, for the opportunity to share this recent publication and this, I think, really important contribution to the bone sarcoma clinical care, titled, I switched Ewing's and osteo for this group. So optimizing osteosarcoma and Ewing sarcoma biopsy acquisition. A Children's Oncology Bone Tumor Committee consensus statement. I'm presenting this on behalf of the authors. And you might ask, I have no disclosures, but you might ask yourself, in like 2025, do we need a consensus statement about how to biopsy a bone tumor? What else is needed besides establishing a histologic diagnosis of osteosarcoma or Ewing sarcoma? And I think advances in tools for biological evaluation have really occurred significantly over the past couple of decades, which really allows us to kind of refine a diagnosis, identify subtyping and prognostic factors, and things that are really position us to do better for patients. And molecular risk stratification really is a standard practice in solid tumor. And you can look at examples here, like neuroblastoma, for which there are many molecular risk stratifications, but the one I chose to highlight was NMIC amplification, which we know is prognostically poor and has led to some risk-adapted therapy. And kind of looking at this is can be done molecularly or with FISH testing, and you can see all this green signal is too much of this transcription factor NMIC that really kind of drives aggressive features in this cancer. And then there's really kind of what a success story in infantile fibrosarcoma and identification of this NTRK fusion and a targeted therapy. For example, larotrectinib or these kind of NTRK class inhibitors that have really fundamentally changed the way that we treat infantile fibrosarcoma or can treat it. And then Wilms, another childhood cancer where we've been able to identify loss of heterozygosity or imbalances in kind of how many chromosomes or parts of chromosomes there are, and associate risk with that, and then adapt therapy to achieve outcomes that are better for that group than they were with standard therapies. And so this is an example of a microarray where you can see this gain of a part of chromosome 1 and this loss of a part of chromosome 16. And a lot of these are molecular tests that are really kind of predicated on having nucleic acids and kind of some of the fundamental building blocks of cancer cells available for evaluation. And if we look kind of currently what we have for osteosarcoma and Ewing sarcoma, it's relatively limited what we have for prognostic or predictive indicators. Kind of the current state is metastatic disease we know is prognostically challenging. We know larger tumors are challenging, associated with more likely to recur or metastasize, older age, and then some response like percent necrosis, margin status. These kind of all have influence on the likelihood of achieving a long-term cure for these patients. But a future state could look like identifying subgroups of osteosarcoma or Ewing sarcoma where we know they're more likely to be in the group who respond to treatment, or more likely to be in the group that we thought should have been cured of the disease, but then weren't. Opportunities to identify circulating correlates of disease. I think with David Schulman and Brian Crompton and a lot of others have done work in the cell-free DNA space. And is this another tool that we can use to ultimately create risk-adapted therapy? But to get to that state, we need to have access to well-preserved tumor specimens, primary patient samples. Cell lines aren't going to be able to get us there. And this is challenging in bone sarcoma. And it's challenging for a handful of reasons. And I highlight them here. So fragmented or decentralized care. This is true for a lot of adolescent and young adult tumors. And we know that's the time period where we see most Ewing's and osteosarcoma, because their care can span adult and pediatric institutions. And then there are some processing requirements or pre-analytical factors in the bone sarcoma that matter. And then a lot of this needs to be anticipated when you're first meeting a patient and doing this. And so if we kind of look at the decentralized and fragmented care, a patient might present and get with pain or a lump and get imaging and referred to get a biopsy or get an evaluation. And that might happen, if you take a 17-year-old and they're out in the community, that might happen at the community hospital, that might happen at a procedure center, an adult hospital, they might go to a children's hospital. And then that tumor gets sampled and you have now this specimen, and that might be processed right there at the same kind of biopsy center, but oftentimes it's not, and it can be sent to a central pathology processing, it can be sent to a reference facility, or there might be things like commercial molecular testing that wants to be done, and that's done completely kind of at separate sites. And then we have the patient who now has the tumor that's been biopsied and the diagnosis of osteosarcoma has been rendered, or Ewing sarcoma. They're going to go on and get treatment. And that might happen at a center that's different from the biopsy center, different from the pathology center. And yet this treating center really needs all of the information from these past centers. And I think one of the things that we've learned in sarcoma is that fragmented care leads to more complications and more problems, specifically looking at a diagnosing center versus a treating center, that there are more problems and more events for patients when their care gets spread out like that. And so adolescents and young adults, I think, are particularly vulnerable to that. And if we just kind of look at tissue acquisition, trends in biopsy procurement have changed over the past 2 decades. Open incisionals, like you go to the operating room, the orthopedic surgeon goes and cuts open and takes out a tumor, used to be the gold standard, and it's certainly still a common modality. But imaging guided biopsies have really grown in their use in the past couple of decades. And the importance here is that not that one is better or worse than the other, but the quantity and the quality of the tissue can vary between those procedures, and they can vary between institutions. So all of this is kind of happening even before patients are getting to have a treatment plan, but all of this directly affects that. Just as an example, the Children's Oncology Group has a biorepository for bone sarcoma. And just a couple of years ago, there was a quality assurance process that was done to look at the specimens in there to ensure that, have expert pathologists look at them and say, does that align with the submitting diagnosis? And 10% of the time, it didn't. And that doesn't mean that 10% of the time there was a misdiagnosis, but there was a discordant diagnosis, almost 4 or 5% of the time, where something was called osteosarcoma, but maybe it was chondrosarcoma or vice versa, or other kind of small round blue cell tumor variants. And then in many of the cases, there really wasn't any kind of viable tumor there to substantiate the submitted diagnosis. And kind of when they honed in on the ones where there was discordant diagnoses, it seemed like there was variable amounts of tissue that could have been played a factor in really having a diagnosis rendered. And so I think these are important because this directly matters to patients. It directly matters to how we are going to come up with treatment plans. And then there's the unique processing requirements of bone tumors. Histology, histology is really the cornerstone of pathology, and that largely involves taking that tumor biopsy specimen and taking it through a process to get it into a paraffin block where it can be sectioned into thin layers and put on a glass side for a pathologist to review and establish, what it looks like under the microscope in a diagnosis. And bone tumors are hard or can be hard because of the calcium and the osteoid that's in them. And so taking them through a microtome is a problem. They don't cut very well. So you sometimes need to do a process where you decalcify the tumor tissue so that you remove the calcium so it becomes more flexible and malleable and can get sectioned on a microtome and a slide. Depending on the decalcification technique, it can have really significant consequences to any downstream analysis, whether that's even the histology, the ability to do stains on that tissue, the ability to do future molecular testing on that tissue. And so this can really compromise what we're doing. And kind of at any institution, there's tons of stored tissue blocks for residual tissue, but we're limited in what we can do with them if the way that they've been decalcified creates a problem with the nucleic acids or other kind of investigations that would want to be done. So you could be potentially storing stuff that really has lost its value. And that kind of comes to this next part. When the pathologist, when the proceduralist, interventional radiologist, or the orthopedic oncologist are seeing these patients, we kind of need to be thinking about downstream uses of that tissue up front in anticipating that. And so for bone sarcomas, it might be that there's a need for expanded clinical diagnostics. We can't quite tell, is this a very small round blue cell tumor? Is this osteosarcoma? And so immunohistochemistries or stains can be used. And then a variety of molecular techniques that look at pieces of DNA in different spots, or next generation sequencing, or maybe not in huge commercial use at this point in time, but methylation profiling, sending tissue for second opinions. This all uses tissue and it needs to be preserved and kind of maintained in the right way. And then other downstream uses that might not be thought about up front. But tissue is a common requirement for an entry into clinical trials. And we know certainly in pediatrics, and I would say in bone tumor, it's standard practice to offer a clinical trial if you have one available to patients and families. And if there isn't a clinical trial, there's lots of biologic studies that are trying to do things like understand molecular risk stratification like we have for other tumors, but they require tissue for that. And then there are institutional biorepositories where places are doing great bench work right there. And so they're holding on to these specimens, left specimens or specimens that patients go and consent for getting additional tissue for. But all that needs to be anticipated at the time of biopsy. And so our colleagues across the pond half a year ago, maybe a little bit more, they provided a perspective about, about how to optimize research specimen collections. And there's a lot of correlation and similarities with the work that we did on this manuscript about optimizing biopsy acquisition and processing. But one of the things that they included in here was an ongoing, survey research study where they're reaching out to patients and families and just gauging their interest in participating in biology-related research with their clinical specimens. And the resounding response was they're very interested in having access to having their specimens go into research use. And so this isn't just for scientists, right? This is patients and families who are really interested in trying to help move the needle and advance the knowledge. And so when we kind of looked at this backdrop in the bone tumor committee, we said there really needs to be a standard clinical practice guidance for how to best procure, process, and kind of triage or evaluate tumor biomaterials from these bone tumor specimens. And so what we did was we convened a group of multidisciplinary folks, whether that's interventional radiology, orthopedic oncology, pathology, radiology, obviously pediatric and medical oncology scientists to say, how can we do this so that we can put something out into the literature that would reach a broad audience, not just pediatric oncologists, right? But we also want to reach our interventional and orthopedic oncology, reach our pathologist. And so we created this consensus statement, and we really tried to hone in on these specific pieces. Like I said, the fragmented care, the processing requirements, and downstream uses. And how we thought to organize this was to say, like, this really needs to happen around the patient. And so when we created this kind of workflow, we thought we would put the patient at the center, and we'll say, how do we make sure that this patient has preservation of the opportunities for participating in research, for having adequate tissue for diagnostic purposes, and really has coordinated multidisciplinary care. And it's clear that a pre-biopsy meeting is really important to that. And so what we did here was kind of identify the pathologist, the orthopedic surgeon and the interventional radiologist, and then oncology, pediatric or medical oncology, and showed this kind of tri-directional communication of things that should and would be beneficial to discuss prior to that tissue acquisition. And so if we kind of look at, I call them the proceduralist, and I know that they hate that term. I don't mean it that way. I meant the person who's getting the tissue. But that could be an interventional radiologist, that could be an orthopedic oncologist. And the conversation would be around, like, do we have adequate pre-biopsy imaging? We know a lot of times people will get an MRI of the knee, and you don't get the entire femur when that, so you can't identify if there are skip lesions, or less frequent in Ewing's and osteo, but lymph nodes will be abnormal, and we'll realize that after a biopsy, and then the patient needs to go back to get that sampled. So do we have all of the right imaging that we want before going in and procuring this tissue? And then what is the biopsy approach? There are imaging guided, there are incisional or open. And how should we think about that with future local control needs? You know, a lot of times when we're seeing abnormal imaging, we have a good guess in this age bracket around the likelihood of what that bone lesion will be. And so we can try and say, all right, is this somebody who's going to have, you know, an endoprosthesis or a limb sparing surgery? Is this a radiation candidate? And then how are we going to manage the biopsy approach? Because we know that seeding of a biopsy track is certainly something that's a risk and can be associated with local recurrences. And then, do we think this is going to be challenging in a way, or know that molecular diagnostics are going to be needed? Are there clinical trials or biology studies that this patient would be eligible for? And we need to think about how to handle the tissue that's coming out of the IR suite or the OR suite. And you know, what's the amount of tissue to get? And so, sorry if this image is graphic, but just showing kind of an open biopsy here where the skin's open and you get down to the bone, and you can see this pretty decent sized, you know, cube of tissue coming out, versus an imaging guided cord needle biopsy where you can see this abnormal X-ray here, and then certainly you can see this kind of expansile lesion here on the tibia, and then you can see the patient going in and getting an imaging guided biopsy. There's a variety of different needle types that can be used. There's a variety of different gauges of needles, and these are all can influence the return of tissue and how much you're getting. And in general, when we're doing patients undergoing an imaging guided core needle biopsy, we're getting less tissue as compared to an open incisional biopsy. And so how can we assure that the tissue that we're getting is going to be able to meet the needs of that patient? And so,
Dr. Dietz, quick question for you. For the pre-biopsy imaging, what type of imaging is usually preferred? Is it MRI, a CT?
I think a lot of the times the orthopedic oncologist, so in Utah, we do a lot of open biopsies. And for them, it's helpful to have the MRI because actually, believe it or not, for a lot of bone lesions, there's a soft tissue component that has broken through the periosteum, and sampling that soft tissue, even if it has some osteoid and bone in it, is more straightforward than cutting out a cube of bone. And so you can't always tell that on a plain film X-ray. And I would say plus or minus on a CT. So in general, we'll try and get an MRI and get it of the entire bone involved. I'd say we do a lot of repeat MRIs for a knee MRI, which is good for looking at the ligaments and the whole like, but stops, 1/3 of the way up the femur. But yeah, so I think MRI is probably with the most information.
Got it. Thank you.
And so that conversation with oncology and the interventional radiology or surgery, it's not in a silo, but another conversation that oncology is having with pathology is like, what's this clinical situation? Is this somebody where we really want to be able to start therapy quickly and the biopsy is happening on a Friday? Because that might mean, depending on where you are, that people need to come in and do immunohistochemistries on Sunday after the tissue is preserved, as opposed to waiting until Monday and starting all of that. Or maybe just like the great uncertainty that there is about this lesion in the clinical scenario. And so you say, like, I anticipate this might not be straightforward. And so, what other expanded workup do we think we might need ahead of time, and have the pathologist thinking about that in addition to the oncologist? And then similarly, the clinical trial needs. If the pathologist is getting tissue, they also need to be aware of this patient might be eligible for an upfront study. And so this is the tissue requirements. Do you think that we'll be able to have that once you do all that is necessary to render a diagnosis? And then how to preserve that. And that kind of all comes down into this grouping of like tissue allocation. When you get the tissue, what are the things that we need to do with it to, again, do the most for this patient with this tissue? And so tissue allocation, I mean, this is something that a lot of institutions can have a formalized or standard operating process. It's something I was really involved with kind of when I first came out here to Utah. And so when patients in the procedure room and they're getting, here I chose to show core needle biopsies and show 7 little pieces here. The pathologist, how will they take and say what should go into formal and fixed paraffin embedded process so that we can do standard histologic diagnosis? What can be frozen? Because oftentimes our molecular testing is better done on fresh frozen tissue than paraffin embedded tissue. Paraffin also complicates nucleic acid evaluations, but because there is so much paraffin embedded tissue, we've been able to identify what are the common ways that it is complicated, and then create redundancies or ways to know that. So it's not that you can't do some molecular and paraffin embedded tissue, but it probably performs better on frozen tissue. And then, is there the opportunity to do either a research banking if the patients have consented to that upfront, and that might be freezing the tissue down in a media that allows that to be thawed and still be viable tissue for the future, for either generating cell lines, tumor mouse models, doing more detailed molecular analyses. And so kind of having all of this in the pathologist's head when they're getting that tissue. Not all the time are certain of these available in a pathology department. And so you would have to plan a little bit to make sure you had it. And then just going back to that.
I didn't realize, so is the tissue always, it's minced before it's frozen?
Often, well, it depends. If you're freezing it in like a media and your hope is to future grow that tissue, when you chop it up, the DMSO and the kind of tissue, the things that support those cells to be alive, there's just more surface area to have access and exposure to it versus like a cube of tissue where you've got some diffusion limitations. And so, I mean, it's not an absolute have to, but I would, for us, we mince it up before we freeze it.
Yeah, that's so interesting. I didn't know that.
And there are, as you might imagine, there's a variety of ways and commercializations of mincing tissue. And so there are like, yeah, different kind of automated processes, but simple cutting works pretty well. And then just kind of reminding ourselves that decalcification process really affects a lot, almost all of this. And so having that in the pathologist's mind is important. And this just kind of is a couple examples of that. So harsh acids like hydrochloric acid or pure formic acid can decalcify, get rid of the calcium in the bone relatively quickly. And so for big specimens or things where you're not anticipating the need for nucleic acids, this is a common approach, but we know that it can affect the histology. So even just what it looks like, the immunogenicity, which means the stains, and the nucleic acids. And here's just an example of kind of pure hydrochloric acid, and on these, for example, kind of brown is signal from the stain. And so just you can see this brown nuclear stain here that's really not appreciated over here. Ki67, another nuclear stain. So there are just examples where you kind of lose your ability to interpret what can be important immunohistochemistries. And so, so we do not prefer this to be done on especially biopsy specimens, which tend to be small and oftentimes don't require decalcification if they're from that soft tissue expansile component of the tumor. And so these soft decals like EDTA or like diluted formic acid solutions can better preserve the histology, immunogenicity, and nucleic acids. And this was a study just looking at DNA yield from agent type 1 is kind of soft decals, agent type 2 is harsh decals. And so this is DNA yield, so just how much can we get out, and this is RNA yield, because that's what's kind of necessary for next-gen sequencing testing. And you can see that significantly more DNA and RNA is able to be obtained when a soft decal is used. And then this looks counterintuitive because the soft decal shows a lower. This has to do with the quality of what's coming out, the RNA and the DNA and the RNA. And this kind of measure is like, how many cycles does it take to have an output? And so the lower number indicates a higher purity, higher quality of nucleic acid. So really kind of showing concretely that we can do okay with preserving nucleic acids, but we just need to use optimal decalcification techniques when they're needed. And this is focused on Ewing sarcoma, but this is important. This isn't all just research based, though that's also important. I mean, Ewing sarcoma, small round blue cell tumor, CD99 on the outside and NKX2.2 in the nucleus are kind of common immunohistochemistries. But some of these, what we have learned, are different. Undifferentiated round cell sarcomas can look like that under a microscope and can have really similar histology and immunohistochemistries, but they're distinct entities. And some of them, even if you do a FISH probe for EWSR1, looking for this rearranged gene that's in Ewing sarcoma, it can be rearranged with partners that are not consistent with the diagnosis of Ewing sarcoma. And so really there is a need to molecularly define this diagnosis of Ewing sarcoma, and you can't do that if the tissue's been acid degraded. And so this reaches patients, and I know we're talking about osteosarcoma, but this is, the hope is that we can have kind of refinement and biological subtyping in osteosarcoma in the future. So here and I are thinking about the proceduralist and the pathologist. The pathologist needs to be talking with that surgeon or interventional radiologist about like what are the tissue requirements? How many cores, if we're going to do we need? What's the gauge of the needle that you're going to be using? Is this a bone lesion? Is this a soft tissue lesion? And then how to submit that specimen. Submit it fresh. Do put it right in formalin in the OR? No. If you're going to do any kind of rapid on-site type of assessment for adequacy, how are we going to freeze the tissue? How are we going to do that to have the pathologist look at it and say, yes, this looks like lesional tissue, or this is all necrotic, or this is all kind of fibrotic. And then, things that I haven't had to think about because we do a lot of stuff here, but if you're at a procedural, suite, they might take that biopsy and they might send it out to Quest Diagnostics or ARUP, which means like that tissue needs to be shipped. You can't do something fresh and immediate unless you're really planning on that. It's like, what's the courier timing? How are you going to preserve this tissue? All of those things really are critically important and need this kind of conversation here. And so when it comes to tissue adequacy from a biopsy, it's not just the number of times that a needle went into the tumor or the size that the surgeon took out. It has to do with the viability of the tumor, the cellularity, what's the content in that specimen. We know tumors grow and outstrip their blood supply and can die. And so you might sample just a bunch of dead tissue that doesn't actually get you the diagnosis, even though you were smack in the middle of the tumor. And so we provided in this manuscript some kind of frameworks for about how much tissue we think is beneficial for establishing a diagnosis in kind of all of the patient's needs. An open biopsy tends to not be an issue of getting sufficient tissue. These tend to be, a centimeter or even more, which can correlate to a gram or more of tissue. But open biopsies, certainly, you have to go to the operating room, and it's a little bit bigger of an intervention than an imaging guided biopsy. And so for imaging guided biopsies, if really we have a bone only lesion, there's not that soft tissue breakthrough, getting larger or smaller gauge, which means larger bore needles of that bone is really important. And so kind of as gauge gets smaller, the amount of tissue that's in there gets bigger. And so, I don't know, just for like the thought experiment, a 16 gauge needle gets about 12 milligrams of tissue, depending on the length, if it's a centimeter or more than a centimeter. And so you might need 70, 80 biopsies to get anywhere close to a half gram or a gram of tissue. Now, we're not saying to get 70 or 80, but just to show how much more is getting with an open biopsy and why it is so important to make sure that you and your IR colleagues have a number of cores that you're hoping to get and that they're evaluated for adequacy based on viability, content, and volume. And so for when there's soft tissue breakthrough, you can use a smaller gauge needle and get like 15, 20 cores, which should provide enough tissue for both the histologic, molecular, and any other downstream uses. So we put this figure together, which really kind of brings all of that home and goes through what is the quantity of tissue that we need. We should have a check by pathology to say, does it look like, if we can, does it look like it's viable tissue? Does it look like it's lesional tissue? That's not always possible. And that's something for procedure centers and for oncologists to think about when their patients are getting sampled somewhere. And then, making sure that we've got the appropriate tissue preserved for standard clinical diagnostics as well as for expanded and molecular diagnostics. And one thing that's, if you get 8, 10 cores, you can fit them all into the block that makes into the cassette that makes that wax blocks. But the downside is that every time you cut a layer off of that, you're using a lot of tissue. If you separate that out and only have 2 or 3 cores in a block, you can really spread out the use of that tissue. And so just calling attention to that and really to only use decalcification techniques when we think they're necessary and to use those soft decals. And And then here for future clinical and research needs, talking about SNAP freezing tissue, which can be done with liquid nitrogen, or it can be done with Mr. Frosty's brand, but these kind of containers that bring down tissue at a consistent rate to best preserve it for future. And then fresh viable, where we need certain medias to help keep the cells healthy while they freeze. And so in this figure, kind of running through like, well, what are we going to do? Kind of made reference to some of these things, but what can we do with these various tissues and the way that they're preserved? What can we do clinically, and what can we do on a research basis? And so this is the workhorse of histology, the formalin fixed paraffin embedded tissue, and if that can use FISH and morphology and H&E, and you can make tissue microarrays, so you can sample that tissue from 75 patients and create a high performance block to look at a disease, but that's more of a research use. That frozen tissue, really valuable for things like next generation sequencing or molecular evaluations, PCR, which can be both for clinical use, establishing a diagnosis, for kind of expanded workup, refining a diagnosis, as well as for future research applications. And that fresh tissue, when we're talking about media or otherwise, this can support like mouse xenograft programs, where you can kind of have patient, avatars of the patient's tumor and assess different treatment modalities, as well as a variety of other things, single cell sequencing, cell line generation, etc.
I love that slide so much and find it so helpful.
Oh, I am glad to hear that. I will another time I'll tell you a story about when I was trying to build this slide. And so just looking at this slide and saying, all right, so we've established there are clinical uses that are really great for this tissue, but what are some of the research opportunities with this tissue? And ones that could be really quickly clinically relevant. And so, for example, for Ewing sarcoma, there are a variety of candidate biomarkers. This is a publication from a year or two ago. David Schulman was the first author, but it was an international paper kind of looking and saying, what do we know about risks for adverse outcomes in Ewing sarcoma? And so there's, like I said, some of the ctDNA work, some of the clinical features, stage, and the like, but then some copy number alterations seem to, or can have an association with an adverse outcome, or different mutations, STAG2 and P53 can be associated with inferior outcomes, or having chromoplexy, or just a complex genome in these tumors, not just a simple EWSR-FLI1 rearrangement. And then the different types of EWSR-FLI1, when you bring these genes together and you create this oncogenic transcription factor and the associated protein, they're not all the same, the output of them, and some of them may be more immunogenic, or some of them have a different prognosis. And so the idea being, with some of these things, we're close to saying like this is definitely associated with an inferior outcome, and we could start risk stratifying therapy based on that. You might have a patient who say, you should be in the population who achieves a cure, but you've got a P53 mutant, so I know that is unlikely. And so rather than giving you standard of therapy, you should have at least opportunity for a study that brings in a new agent or changes that to do better for that outcome. In osteosarcoma, this work is ongoing as well. A little bit behind Ewing's, just because I think largely because of access to tissue. And Amanda Marinoff, who has presented at Factor and done MIBs or OsteoBites before, is leading a project called CBOS, which is looking at biomarkers for osteosarcoma. And this is adapted from a CTOS poster with her permission. That's applying similar things for risk stratification and biomarkers. Like we talked about some of the upfront stuff in the cell-free DNA. but there are certain epigenetic signatures that Alejandro Sweet-Cordero's lab has looked at, and others have copy number alterations similar, not necessarily the similar copy number alterations, but concept to Ewing's. There are transcriptomics and groups that kind of subclassify based on what is the output of the DNA to RNA to protein. Tumor microenvironment signatures that are associated with risk. And then loss of heterozygosity or kind of changes in the DNA. And Amanda is saying that whole genome doubling wasn't something that they had particularly robustly established yet, but I think that's also a marker that is potentially associated with inferior outcomes. And so these are all areas that are really require tissue and require clinical tissue, and ideally clinical tissue with annotation. So if you don't know what a person got treated with, and if you don't know if they had a recurrence or were disease-free, the utility of that tissue is a lot less for generating biomarkers and risk stratifying and risk adapted therapy. And then, just so those are kind of getting closer to the clinical mainstream, but there are downstream research applications where fundamental mechanisms of pathobiology are being discovered. And Isidro was at Factor last year, and I can't remember if he's done an OsteoBites, but he did some really, with a handful of colleagues, some really, really cool work looking at how osteosarcoma is so genomically complex and what are the mechanisms, and could this be true based on what we know of mechanisms of developing genomic complexity from other cancers? And the answer was, well, no, it's not completely explained. And this concept of loss, translocation, amplification, chromothripsis, and how the osteosarcoma gets so genomically complex kind of came out of this work, and other potential biomarkers for risk stratification have come out of this. And I think not specific to Isidro, but also just showing that different areas in the tumor have different osteosarcoma in them. And so that calling this all one thing is probably, or saying it's all genomically the same is probably inaccurate. So I think there's a lot that can be done with this tissue if patients are given the opportunity to participate in biologic research, and the way that their tissue was procured, processed, preserved. And I think, as we saw from the group and our European colleagues, there's a big appetite for it. And not all of this even has to happen through a center in a clinical trial. I think Dr. Katie Janeway was on here at some point in time talking about the Count Me In project and the Osteosarcoma project, where patients can request their tissue be sent for a biorepository and bioregistry, and where you're treated doesn't have to have that study open. You can be consented. And so that's bringing it right into the hands of patients. And then there are certainly cooperative consortia that have studies open at a variety of sites. I mean, the Children's Oncology Group has this A Project Every Child, which any patient diagnosed with cancer kind of at a COG institution can participate in. And there's a sub-component called the Molecular Characterization Initiative, where tumors and Ewing sarcoma is now being added to it, not yet osteosarcoma, and that should be in the very, very near future, where there will be really deep sequencing of the tumor, as well, with return of results to the families, as well as to the providers, as well as germline testing. But it requires that tissue not be decalcified. It requires all these things that, believe it or not, still happen at a lot of institutions. And so our goal, part of the goal with this manuscript, was to say, how can we help everybody be ready for this next generation of diagnostics and opportunities for patients? And then couple of other ones here that are biology studies that patients might want to participate in, but we really need to have tissue to allow them to. And so with that, kind of bringing it all back together, we created this quick reference checklist so that somebody can go to their interventional radiologist or orthopedic surgeon and say, like, all right, we had our multidisciplinary discussion. We talked about how much tissue needs to be procured. Do we have an ability to do a viability check? All right, great. Have I talked with the pathologist to say, yes, we can do a viability check. There's the way to assess this tumor. We know how we're going to triage it. And we know how, if a patient's interested in research either upfront or in the future, that there'll be preserved specimens. And so that kind of was bringing it all home. And I'll stop there and say thank you to like the many patients and families that really kind of drive us to do this work. The COG Bone Tumor Committee was really, really helpful in helping me move this forward, to Christina and to the MIB agents. I think this is just such an amazing, amazing resource for patients and families and the scientific community. And then Kelly Bailey and Ryan Roberts were just really, really great in helping me get this over to the finish line. And so I'm very grateful to them and welcome questions and comments.
Thank you so much. It's always, I think you kind of make it look easy, but I think people underestimate kind of what a huge lift it is to get consensus across, all these folks and actually kind of get it over the finish line and publish. So kind of amazing effort there. And also just, I think this reminds us that it's so important in rare disease like Ewing's or osteosarcoma that this tissue is such a valuable commodity, not just in helping determine the patient's treatment plan, but also just driving research. So this really kind of helps, I think, level set and hopefully kind of drives more of that. But I think, Max, if you want to kick us off with some questions.
Yeah, so our first question comes from the chat, which says, is it common for osteosarcoma or Ewing sarcoma tumors to infiltrate nearby tissues, for example, the muscle? If so, how does this affect diagnosis?
That's a really great question. There certainly can be infiltration of kind of adjacent tissue, but sarcomas tend to push a lot. And how that affects diagnosis, it can affect it because, like, let's say you've got a big tumor at the distal part of your femur. Well, you got your quadriceps all lying over the top of that. For osteosarcoma, we know that we want to take a layer of healthy tissue around that tumor when we take it out so that we can have adequate margins. And so if a biopsy tract accidentally goes through all of your quadriceps or, multiple of them, that needs to get resected. And so there are different ways that orthopedic oncologists and interventional radiologists know to go so that they're not exposing as much tissue to that, important muscle tissue for driving the leg and doing the muscular functions. So even if it doesn't invade it, the definitive surgery for it can certainly affect those, and how we biopsy it can have implications for that.
Mm-hmm. And then I just had another question. I thought it was really interesting how you talked about the pre-biopsy multidisciplinary discussion between oncologists, pathologists, interventional radiologists, and surgeons. My question is there like a standard process or timeline that you do these conversations with, or is it mostly personalized for each patient?
I think it depends. So we the institutions might have tumor boards, and if those meet at a regular enough window, I got a referral for so-and-so with this mass, like, let's make sure we're all on the same page. Or sometimes it's ad hoc, and that happens too, where I'll get a call from our orthopedic surgeons and say, hey, Matt, I just got a call from this person. I'm going to get them into the OR tomorrow. How do we make sure we're all lined up? For me, I think the parts in sarcoma care and multidisciplinary care is somebody needs to kind of make sure that all of the pieces get into place, and that can be considered a burden or like a joy. And I really like that, and making sure things get executed really well for that patient. And so I might make sure pathology knows so that the surgeon knows. And I guess, sorry, Max, the other part would be like, if you work and establish standard practices ahead of time, like I don't need to call the pathologist and tell them to snap freeze tissue to do all that, because they know that. We know we have a bone specimen coming because we've worked and we've done that and we've done that. But that may not be true everywhere, and this might help create the foundation for that.
Dr. Dietz, I had a question. You, in the very beginning, you kind of had this interesting slide that just kind of showed how, diagnosis can happen. One institution, pathology could potentially have like the fragmented, thing happening. And so I know that this has been kind of published as part of the NCCN guidelines, but I'm kind of wondering, like, again, like in execution and practice, like how does this get communicated across institutions, and particularly maybe some of those community hospitals that don't see a lot of sarcoma cases, and also just even things like, is soft decal like a standard thing on the shelf in the pathology lab?
These are great questions. So to the maybe the first one. So practicing in the Mountain West, we have a lot of outlying hospitals that might see a patient before us, but most of them are going to come here for definitive management. But what really has helped is that our orthopedic oncologists have a really good relationship with referring providers, and so through time and they say, all right, well, we're not going to biopsy here, we'll send it down there for biopsy. And that's also feedback, which is hard as a professional, to be honest, but everybody wants to do the best for patients. Like that is what we're all trying to do. So if a colleague says like, hey, I biopsied this patient, I'm sending you the, the paraffin tissue. My goal is to try and say feedback, for future patients where we're doing this, share this, maybe share this paper with them, or share something that shows like, hey, here's how we're trying to advance the field. And so to do that, we need to have the tissue processed differently. And maybe that's best to happen at this location. Like I think this paper says practice change might need to happen at some institutions for the betterment of patients. And to the question about soft decals, that honestly, that's something I started working on a little bit when I got here, because we didn't have all of them. That was only 5 years ago. And it takes a lot actually to get a new reagent on a shelf in a pathology lab, especially if you're part of a healthcare consortia. But it was just persistence and bringing them papers like this, showing how we ultimately need to do this for patients. And now we're fortunate that that's a standard practice. And I think it's growing in being a standard offering.
Yeah, I was like, I think MIB Agents is going to be sending out soft decal as like stocking stuffers this year.
Yeah, that's a great idea.
Yeah. And so in the beginning, so at biopsy, right, this is that nice circle graphic, you have this conversation that's happening. So there's like, there are like different priorities, right? And I'm kind of wondering, how do those priorities get set? So for example, like the institution may have their own in-house testing. If you're at, a big ped cancer institution, likely there's in-house sequencing versus sending it out to, like a commercial testing lab. Or for example, if they're being consented for Project Every Child and, you want to save some tissue to be sent for the COG biobank, kind of who prioritizes that?
I think it's a conversation with pathology predominantly, because they're the custodians of this tissue. And the first and most critical element is making sure that everything is necessary to establish a diagnosis and get the clinical, necessary for the clinical care of the patient. That's number one. And so they don't have a crystal ball, but they're pretty good at guessing like, all right, I think this much tissue and paraffin is sufficient. And I want to snap freeze stuff because I think we're going to need to do sequencing on this. And so it's really with pathology to make sure that they're comfortable with the amount of tissue they'll have to issue a report and help that patient. And then in terms of priorities for where you might send next-gen sequencing, let's say, some of it has to do with what your target is. It's not all just a fishing expedition. Like, so in rhabdomyosarcoma, for example, there's MyoD1 mutant, which is an activating point mutation that's not on every commercial NGS next-gen sequencing panel. And so hopefully your oncologist or your pathologist are paying attention to that so that you can send the best test for that tumor type to the best lab. And some of that's working that out with your pathologist and saying, here's how we want to do this, or maybe they're working it out with you. And then for tissue priorities, it's the pathologist and I think the oncologist that are largely in that discussion. And so that it might be that there's really important work going on at your institution in osteosarcoma. And so getting that up to Kevin Jones or to Martin is so important. And you're going to say, I think that's more important than getting this onto a cooperative study. And so you might choose to do it that way. Sometimes it's actually talking to the patients about what they would want to do. And say, like, we have limited tissue. One would go into a mouse here. One would go into a future use could go into this or that. Do you have what's important to you right now? Sometimes they'll have opinions. Sometimes they're like, do whatever you think.
Yeah, that actually, I know we're pretty much out of time, but I did want to just kind of throw in one last question. Totally good segue, thank you, which is, at biopsy, I think the patient and their caregiver is they have no idea what's going on, right? They just got diagnosed with cancer and they don't even know what a pathologist is or what tissue is or anything like that. But if there is, once you get to resection, or if you have relapse and resection, then at that point, the patient probably has kind of been in it a little bit longer and is kind of aware of what some other options might be, both in terms of testing, whether it's commercial testing or other studies at other institutions. And so kind of wondering what your thoughts are on kind of the patient's role in that discussion and the prioritization, and also just how these guidelines, as a part B to that question, how these guidelines apply also to resection, not just biopsy.
Yeah, great, really great questions. It's really hard in the upfront setting when you don't, if your parents, your child, or you're the patient, you don't know anybody in this equation. I think one of the ways that we try and build trust right away is by saying, like, we've talked with the surgeon, we've talked with the pathologist. These are the steps that we're going to take, and kind of really trying to quickly build some of that trust. And then honestly, a part of it too is getting 15 cores or 20 cores probably is completely like a non-issue for that patient. Taking 3 mLs or 5 mLs of blood, like it's just not an issue. And because maybe 8 cores would be enough because they're all pure tumor, they're completely great, but you don't know that until they're processed. And so hedging and having tissue so that you don't have to repeat biopsy, I think, is one of the ways that we can help preserve patient autonomy for wanting to participate in research and protect them from the need of repeat biopsy, likely with exposing them to no more risk. But I will say that is distinct from saying we are going to take these 5 cores and they will never be used for clinical use. They will only be used for research. That's a different endeavor than saying we're going to take what we think we need and anything extra would be available for these.
Gotcha. All right. Well, thank you so much. This was really helpful, and I think will be a great resource moving forward. So I'm so glad we caught this on film. Thanks so much for joining us on OsteoBites today and for making it better for osteosarcoma patients. More information on this and all OsteoBites can be found on our website at mibagents.org, on our MIB Agents YouTube channel, and at your favorite podcast place. A new episode of Osteo, which is our podcast, our AYA podcast, where osteoboars spill the tea on living with AYA cancer, is dropping next Thursday on the 20th. And this month, co-hosts Mia and Sammy discuss accessibility wins, fails, and WTF moments. And then we'll be back with OsteoBites on Thursday, the 27th, when we are going to be joined by Dr. Betsy Young from UCSF. Dr. Young will discuss how tumor CCAS sting repression drives immune evasion in osteosarcoma, and is therapeutically targetable via hosting activation. You can find our OsteoBites lineup for the next few months on our website, and if you have any ideas for topics that you'd like to hear about, please email us at events@mibagents.org. Thank you again, Dr. Dietz, for spending an hour with us today, and thanks to all of you for taking time out of your busy days to join us. And thanks so much, Max, also for being our panelist. We hope to see everyone back here on March 27th when we chat with Dr. Betsy Young. Thanks so much. Thanks, Max. Thanks, Dr. Dietz.
Thanks, Christina. Take care.